Yeah, we're live.
Yeah, okay. So I'm just going to give a few minutes for people to join. I think we had over 100 people signed up for this webinar, so it's ticking up quickly. And I guess just while people are joining, I'll just say from my point of view why I was involved in inviting Claire to give this talk. I was not only as she inspired my bake-off exploits, but I was also inspired by your work in 2003 when I was a medical student. You wrote a discussion paper called "Towards a New Politics of Health," which was really struck a chord with me and many of my peers, and got many of us involved in the sort of work that we're doing now. So my name is David Blaine. I'm a clinical research fellow in general practice and primary care at the Institute of Health and Wellbeing. I'm the deputy theme lead for the Determinants of Health and Health Inequalities theme at the Institute of Health and Wellbeing. And I'm really pleased to welcome Professor Claire Bamborough to give this Morris Block webinar. It's the second in this academic year program. Professor Bamborough is a professor of public health at Newcastle University. She is an interdisciplinary social scientist and works across the interface of public health, health politics and policy, social epidemiology and geography. And most of your mixed methods research is interested in understanding and decreasing or mitigating health inequalities, as well as publishing widely, including several books. Professor Bamborough has also recently led the independent SAGE report on COVID-19 and health inequalities, so I can think of few people better positioned to deliver this talk today. And I'll hand over to you now, Professor Bamborough. Thank you.
Thank you very much, David, and thank you to yourself and colleagues at Glasgow for inviting me to do this talk today. Hopefully you can all see my screen now, and I'm going to be talking about the work that we've been doing, which featured in the independent SAGE report on health inequalities and COVID, which was launched last Friday. I'm going to talk about that as an issue, the fact that the pandemic is unequal and the kind of key issues within that. So in my talk, I'm going to firstly put it in a little bit of historical context, that the inequalities that we're experiencing COVID-19 also kind of can be seen in previous pandemics, and I'll draw on some historical data to illustrate that. I'll then present some of the more recent data from Office for National Statistics showing geographical and occupational inequalities today in COVID-19. And I'll then start thinking about what is going on, what sort of pathways explain the inequalities we're seeing. And within that, I'll introduce the concept drawn from anthropology, which is a syndemic pandemic. I'm then going to reflect a little bit about the sort of short to medium term future, beyond the pandemic, how the pandemic itself is potentially exacerbating economic and ultimately health inequalities. I'm then, though, going to sort of finish by arguing that there has been quite a lot of discussion over the last month or so in the media about kind of health versus wealth. And I'm going to sort of set out from the social epidemiology literature about why actually there's not necessarily a trade-off, and outline how social safety nets can matter in the past when we're looking at economic crises and health inequalities, and how they could be used to prevent the current crisis of COVID-19 and economic inequality becoming a long-term health inequalities crisis. And then I'll conclude with a few comments and then open for questions and discussion with yourselves, which I'm very much looking forward to. So firstly, just to set this out, once the COVID pandemic broke, like a lot of colleagues, probably a lot of you that are listening, I suddenly became very interested in infectious diseases and indeed, of course, in inequalities within them. Not something that we had previously, perhaps in the health inequalities community, really engaged with. And so looking back into the research that's looked at the previous pandemics on this kind of global scale draws you immediately, and the parallels were quite quickly made with the 1918-1919 Spanish flu pandemic. And there's some really interesting and important research done by historians, and I think it's quite important that we in public health take on board some of the data that we can get from the work of historians and how that can help us reflect on what's happening now and indeed what we might need to do to mitigate these patterns. So there's a wide kind of wealth, actually, even for 100 years ago, of data from different countries, Norway, Sweden, the United States, England and Wales, showing inequalities that existed in 1918. So the Spanish flu pandemic had a far higher mortality rate than we're experiencing now. Around estimates by the historian Niall Johnson suggests that between 50 and 100 million people died from that pandemic globally. And of course, it's almost like a kind of hidden pandemic. It's until now, it hasn't really been talked about much, certainly not outside kind of historical circles. There are data showing that within that high mortality, there was a much higher incidence of the pandemic and much higher mortality rates amongst, for example, the working classes in Chicago, unemployed and lower occupational groups, for example, in Stockholm or in Oslo. And data from England has shown that there was a rural-urban divide in England and Wales, with mortality 30 to 40% higher in urban areas. And you can already, if you're slightly familiar with what's happening on the inequalities front with COVID-19 now, you can already see some of those kind of rural-urban parallels today. This is some data from Sven-Erik Mamland, and he looked at flu inequalities in what was then called Kristiania, which is for us Oslo today, looking at geographical and socio-economic inequalities. And using data from the time period, he was able to examine how different neighbourhoods in Oslo, he particularly contrasted Grønland, which was a much more deprived area, and Frogner in the west, which is much more affluent. And both these areas, incidentally, remain poor and remain affluent today in Oslo. And he compared them and found that the mortality from the pandemic flu was almost 50% higher in the most deprived neighbourhood in 1918. I also present here some of his analysis looking at how individual level markers of socioeconomic status, here using basically the size of household, to see differences between people who would be classed at the time as kind of more affluent, more upper class, compared to people who were more working class. So properties with more rooms were considered to be an indicator of affluence. And you can see kind of what might be seen as almost a dose-response relationship with people with, as you get a larger property, more affluence, then you get a lower mortality compared to people residing in what would have been a highly overcrowded one-room apartment. So that was data from Oslo. Niall Johnson, historian who did a PhD at Cambridge, wrote a book looking in depth at the experiences in England and Wales of 1918. He compiled a large open access data set, putting the Registrar General's report from 1921, which has all the crude mortality rates for geographical area, counties and so on at the time, into a database and analysed some of that. And here you can see that there was very clearly a north-south divide in the mortality rates from the Spanish flu pandemic in 1918. Together with Niall Johnson, myself and Paul Norman from University of Leeds have done this mapping to present this visualisation of the north-south divide, with the areas that are darker coloured having the higher mortality rates. And what you can also note is not only the north-south pattern and the urban regional pattern, but also reflecting the really high mortality rates. So these are crude unadjusted rates because that's what's available from the time. But you can see in some places the mortality rate was over 1,000 per 100,000 population. And indeed here, using Niall Johnson's data, we can see that the places with the highest rates in 1918 of mortality were predominantly in the north, and those in the south had what places with the lowest mortality rates were all in the south. And you can see the huge range here, with the lowest rate being 188 in Surrey, for example, through to almost 1,200 in Hebburn and Jarrow, just down the road from where I am in Newcastle. So we can see these inequalities in 1918. More recently, what's been called the kind of pandemic that never happened because of various reasons, including